And it looks like Dr. Liebovitz just joined. That's wonderful news. Hello, sir, and welcome.
Thank you. Sorry, I was kind of backed up a little bit this morning, so glad to see we have a great turnout here.
Oh, we really do. And no worries at all. We all understand that patient care comes first, definitely. So I was sharing that we're very fortunate to have the Illinois Prescription Monitoring Program sponsoring this particular series. This is not for CE. So this is an informal discussion with experts such as yourself. And Dr. Liebovitz, aside from his faculty position as a physician with the Northwestern Feinberg School of Medicine, is also the chair of the Illinois Prescription Monitoring Program Advisory Board. So definitely very well versed in opioid risk mitigation strategies, as well as the prescription monitoring program. So we're very thankful that you were able to take time out of your day to join us. My sincerest appreciation. So I'd like to get us started, if it's okay, with basically some informal questions, just to hopefully allow some of us to really learn from your expertise in terms of what you do. And I was hoping maybe you'd be able to share with the audience a little bit about your practice and kind of the color of lens that you'll be speaking from today.
Sure. Yeah, absolutely. Thank you so much, Chris. And so a little bit about myself too. So I'm an internal medicine physician, also clinical informatician. We have a new subspecialty that the American Board of Medical Specialties has approved, clinical informatics. So just for that little dimension, which I also bring to the committee, and that's how I got involved actually originally. With this, it's kind of everything from optimizing electronic health records, that specialty, to thinking about how we can best incorporate the new large language models like ChatGPT. So lots of things. Happy to answer questions in that realm, especially in the context of our opioid prescribing and risks associated, because I think there's a variety of ways in which we'll be able to be helped, and hopefully patients will be able to be helped, and we'll have more layers of safety, which are missing kind of throughout so much of what we do in healthcare. And then from a clinical practice perspective, so I finished medical school in 1990. So I've been in practice for a while. Residency finished in 93, finished medical school at University of Illinois, and then residency, University of Chicago. I've mostly been at Northwestern, except for a brief time back at U of C since then. And throughout, I've practiced internal medicine on an outpatient basis, and also attend on inpatient services here at Northwestern, and also previously at University of Chicago. And so in that, I supervise residents, trainees in this context, and then also on the outpatient side, see my own patients in a clinical practice, and also supervise residents in their clinical practice. And the practice that I'm in, back to kind of the clinical context here a little bit of where I'm working, so is the academic practice at Northwestern. And so we end up seeing, there's whenever you survey physicians, their practice always has sicker patients than anybody else's practice. So I do, of course, feel that's a similar sort of way, but at Northwestern, we have a high transplant volume. So lots of patients have organ transplants. We see the patients who come in from other places for oncologic care, and then have their internal medicine care that they'd like to have at the same place. So we see a great deal of kind of multi-system aspects. And then along the way, lots of patients with chronic pain, patients who come in through the emergency department and follow up, especially in our resident practice too, because if they get admitted to the hospital, they'll follow up with the residents in clinic, and I'll be supervising in that context. So we have patients who've been on recently initiated opioids, long-term use of opioid medications, multiple different chronic pain syndromes with complexity of multiple, organ system diseases. And so anyway, kind of a broad swath of patients.
Perfect. Thank you for sharing that. And I do have some some kind of predetermined questions just to get the conversation started. Obviously, the most important one, I think, that everybody is really wondering, being with Northwestern University, is, are you a Cubs or a White Sox fan?
So, I've never been a super diehard sportsman. However, because we live not too far from Wrigley Field, definitely much more on the north side, going to some games and participating in the neighborhood feel there.
Okay. So when you, as a physician, and I think this is the one that I tend to have the most issue with as well, and the one that the concern that I hear brought up quite frequently, is when you as a physician deem that opioids would be appropriate for one of your patients, what pre-screening tests or assessment tools or considerations do you make? Once you've gotten to that point where you're thinking about initiating an opioid in an otherwise opioid naive patient, what evidence do you collect to further support that decision?
Yeah, great question. And part of it, I think, by one of the important things I try to reassess is, are they truly opioid naive in this context? Is this a patient, understanding the context is really important. Is this a patient I've taken care of directly for many years, and they have an acute issue that is likely going to go away, and that because of other medical problems, because of the nature of the pain and injury and acuteness, that an opioid might be under consideration. So I try to take that full kind of context, most importantly, into discussion. If it's somebody I haven't seen before, that's where I might, and we have some of the screening sorts of tools in the medical record as well, to look for potential risks. But then, of course, someone I haven't seen regularly, and for all patients, initiating opioids, I'm going to be looking at the prescription drug monitoring program to see if things are there. But as we both know, as we all know, with users of this system, it's not always accurate, and patients travel across states that may not be able to share the information. They might have a name that the matching is still not working correctly, and so there's multiple factors I'll take into account. In the simpler scenario, where I actually know the patient, they had an acute injury, and for something that's a nonsteroidal is inappropriate, either from being on anticoagulation medications, having recent GI bleeding, having severe kind of borderline problematic kidney function, other reasons why I might wish to steer clear of nonsteroidals, and that acetaminophen is, likely not up to the task. Although, interestingly of note, on an aside, I'm encouraging more of the Tylenol gel caps or the acetaminophen gel caps of late. Just my personal anecdote, as well as other patients I've suggested, but you can all correct me if I'm wrong, in that they really do seem to kick in faster than plain Tylenol in that regard. So if they haven't tried that, and I think it's maybe possibly going to cover it, at least it gives a more noticeable bump up from seemingly more rapid absorption in that capacity. But anyway, after looking, and this is an acute problem. They have contraindications that are important for other pain medicines, and topical Voltaren's not up to the task. This is where I'm going to consider opioids. We have also built into our EHR some pain smart sets, so order sets that have a kind of variety of scenarios, how to manage pain effectively. So I'll sometimes refer back to that. It has some associated patient instructions and things on that too. So then that can help guide me, if not this, fine. And then we're going to use some of our system constraints that are already built in for short course of opioids in the moderate or severe pain category that necessitates it because of other contraindications. Those are some of the decisions there. And then, just that short supply and most importantly, the patient education side of things. I can keep going, but you probably have other questions about some of this, but just the patient education sides of this. Many patients, fortunately, at least with our opioid epidemic, and hopefully with the deaths that have touched so many of us at different points in time, patients have awareness of it and bringing this up that yes, this medication is in this category where there's higher risk and that's where we have increased scrutiny. This is why it's kind of a limited supply. And this is why it's good for, this acute pain. And so many problems with ongoing use if past this period, but let's get you through this and get more definitive treatment, that sort of discussion.
Dr. Liebovitz, does your approach change at all if you are seeing one of your patients that has a history of chronic pain, that you've moved through the different modalities and now you've kind of backed yourself up into a situation where it's really, maybe opioids are the only thing left versus surgery? Does your decision-making change if it's a patient with chronic pain where you may be making that commitment to initiating opioids for potentially a prolonged period of time?
Yes, exactly. And there's definitely some patients who fall into this category, no question. So thinking, one example could be the so elderly patients who are unable for a variety of reasons to even undergo surgical treatment of severe osteoarthritis or severe back pain. And this is still not something we want to start, in those contexts, because it's not ideal in that context. But in severe pain, in that regard, all other medications are contraindicated. They can't get around. And with that note and with things open, to mention that part of it, there's almost a branch point on that too. So the patients who already been in that context, but something bad happens on top of it, and you've got to go up on the dose for a defined period of time. And then the patients for whom you've done a great job keeping them off it, but now, unfortunately, it's reached that point and are no other options. Nerve blocks, all sorts, have been explored. Nothing is there that I'll do. And then in that sort of consideration, an important aspect is being in close touch with the patient after, initiating in this context. This isn't, okay, you're on it, I'll just give you a long supply, bye, we'll see you back a while. It's really maintaining and ensuring availability in the practice, if not personally, for the patient to be coming in and continue to get monitored. We fortunately still, at least in our public health emergency, although it's going to be going away soon, we'll have to see how this is going to work out with telehealth services. So checking in with patients that way, you can't do the remote urine tox assessments that way, but at least you can kind of have these touch points. So that's what's really most important. And then for the chronic pain patients, so frequent, like almost on that weekly basis, let's check in again, 5 days, let's check in again, and let's see how this is going, just to ensure there's no further concerns. Are we at the right dose? I try not to overshoot on that, especially if this is going to be a long term. So we'll ramp up until let me know, but then only at appropriate intervals. For the patient who needs it, a bump up, they were already on it and things have gotten worse. Just generally in that regard, what I try to do with the patient on the chronic is, okay, you're doing okay, or at the same level. That means your body probably has some level of clearly acclimation to the current dose that you're on, and you're doing okay with this. Let's gradually taper this, even at a really slow rate of like 10% per month, so that if you have another exacerbation, you will be more likely to respond to those initial dose increases should you have it. And so that discussion has actually helped just from ongoing for patients who are stable in a regimen to keep plugging away even at a very slow taper rate for them.
Okay, thank you very much. The next thing I guess I'm really interested in, and probably a lot of the folks that have tuned in today as well, is so you have a patient who has chronic pain that you've made that decision to initiate them on an opioid, and you've gone through the steps to ensure safe use that you just outlined. Now, what is your practice in terms of monitoring to hopefully attenuate risk to monitoring these folks? And could you give us an idea of maybe how frequently you're engaging in these practices.
Yeah, exactly. And also, by the way, feel free, because I look at everyone else on this call is also having kind of experts in the area that they've been working as well. So feel free to put in the chat. Yeah, I don't understand why Dr. Liebovitz is mentioning this. Though that takes a while to type out. No, I would recommend this instead. So feel free to put comments in, disagree. This is something that, where the rubber meets the road, just real life day to day, how we're doing the best we can with patients, which is often beyond, also often not quite reaching what we would like to have in an ideal world. Ideally, of course, it's tough getting patients in on the monthly basis routinely, but that's what I endeavor to do. And partly in an academic practice, we're not as great. From some aspects, we're better situated than lots of practices with other sport. But on the other hand, because it's an academic practice, the residents I supervise in clinic are not there every week. They might be on an ICU rotation. So then someone who might be seeing them is someone they don't know. And then I'm not there every day during the week and may not converge easily with their schedule. They may have to see a different provider. So just from an overall approach, at least doing some, having a checkpoint, ideally in person on a monthly basis for the patients who are on the opioid medications, especially at the higher levels and especially newer onset. Sometimes I might kind of like the patients on warfarin that we still have for our recent Campion, one of the newer agents. Sometimes you'll stretch it out where their INR has been stable for a long time. They know precisely what diet to follow, and there hasn't been an issue. So there may be some of the longer patients, but that's a risk. Ideally, we'd like to have a standard for all, but in reality, sometimes things will go for a couple months with some of the patients. But ideally, coming in and then at least a couple times during the year while they're there, getting the urine test as well, and renewing and reviewing what the plan is for the opioids and the discussion itself with the patient, that we have this opioid contract signed. We have a few safeguards in place at Northwestern. So when I put that in the chart and we have in workflow that's reasonable, that actually will auto update. If another physician sees the patient and they try to adjust the opioid dose in any way, they're going to get an alert. No, do not refill, do not adjust this dose. Dr. Liebovitz has an opioid contract with this patient. Please review this, contact him. So we have some additional foundational safety layers that are helpful in that regard, as well as some of the order sets. And we could put these orders in so they're already ordered and available for the patient to come in on a periodic basis, or just ordered on a standing basis. And you can say, today, let's do this. You don't even have to order it again for the test. And then for the refills, generally, again, we have information in our refill process where we provide context whenever issuing refills. So if someone's out of things, especially in the opioid context, we'll see, do they have an opioid contract? When were they last seen for the visit? When is their next visit? I don't think we're yet pulling in the urine tox on that, which we do for other contexts, which we should update in the in-basket in Epic for it, but it shows at least some of the context. And then when prescribing it, we have kind of a short pathway where our medical record auto retrieves from the EHR, plus the alert, plus the link to the PDMP, plus the FHIR app. So we have several ways to get at PDMP information for the patients when they're at visits as well.
Yeah, that makes me a little jealous. You have all of that with one click. Real quick before we keep going, I do want to point everyone's attention to a comment that was left in the chat by Dr. Huff, who is one of the key folks with the Illinois Prescription Monitoring Program, basically bringing to your attention a toolkit that they have developed and put up on the PMP website that outlines a lot of these things that we're talking about today in terms of best practices. So you had mentioned pain agreement or pain contract just a moment ago. How often do you in your practice re-sign, re-review, et cetera, those? Is it a one and done, or do you try to keep them documented that you've re-signed or re-looked at those on a periodic basis?
No, that's great. It comes up. So when I have it in place, I try to review with the patient. Part of our agreement in this regard is to get to the minimum dose, and so sometimes I'll be referring to it on future discussions after it's in place. So it's not kind of completely done and forgotten because it's providing the context, and I'll refer back to it. Our approach for this, as we've discussed and as we've signed in the agreement, is the following. How we're going to go about this. So it's referred to again in terms of auto updating when it's there. I don't think we actually currently, though we should, have a policy for when that should be done. There's definitely been a lot where our primary effort organizationally, and we have, I'm not sure about the total number of physicians at Northwestern who are prescribing opioids, but because we're a 12 hospital system now and so many different physicians, and it's standardized, we try to standardize the systems across. A lot of the primary effort has been adopting that initial workflow, getting it in place, because then there's other decision support that triggers based upon that pain contract being in place, and it provides the context when the alert comes up to actually go back to it as well. So we haven't focused on, but I think that's a great point. There's always more opportunities to improve this. And then sometimes we're in practical terms where I've ended up having to do it is for a variety of reasons in our practice. Different physicians, I'm just going to be working inpatient, so I'll take over patients who were seeing a different physician, and then I'm updating the contract so it's with me instead of with that other physician that they had before with the shift. So that's most often where I'm like redoing things in practice.
Okay, and just to share with the folks that are online, our health system tries to re-review them and renew them and re-sign them annually. Interestingly enough, the REMS program around transmucosal immediate release fentanyl products, I think they stipulate every 2 years that it be renewed and re-uploaded. So, I don't think there's necessarily a right or wrong answer to it. And, if you're coming back to it, definitely, as long as the patient remembers, what was discussed. So thank you. My next burning question for you.
One other quick thing just to mention on that. It's in the letters, it's in a community. So this was at first a little bit odd to me why we've done it in the communication section in Epic, but because it's in the letters, it's actually available for the patient to see at any time, just from their patient portal, as well as from ours. And we all know now that's where to go.
That's something I need to look into. That's a good idea. So you had mentioned urine toxicology screens. So my first question is there ever a point in time, or have you had any experience with using saliva testing? And then if so, or if not, I guess the more important question is, how do you determine how frequently you're going to do urine toxicology testing on a patient?
Yeah, great questions. I've not been doing the saliva testing. And in fact, I was going to check with that question to see, because I have, I'm doing clinic this afternoon, so I'll be back in clinic. So I have Epic running. So I was going to check and see if we have the saliva orderable easily there. But I've not been doing it. And it's for the relatively small subset of patients that I do have on chronic throughout the year, as opposed to just these bursts where they occasionally need them. And those I'm not really doing the toxicology. I mean, different patients with, occasional for the scenarios I was describing before. But the patients who are on chronically attempting twice a year is kind of a goal in that regard. I'm not sure we're always on the mark, but we're trying in that regard. And for a variety of logistic reasons, patient has to leave, whatever. But we do which could raise other red flags if they can't do it that day, if they're there in practice. If we're interacting online, I'll put it in and then we'll forget to get it the next time. But anyway, that's the best that we're trying. And for the patients on the chronic, where there's a touch point in theory every month that we're endeavoring to do, we really should be able to do better at that. And so I've continued to work with the residents and supervising the others, and patients where there's multiple people in the mix, you would think, well, there's lots of opportunities to be checking. Those are the ones that are more likely to fall through the cracks without it being checked than the ones who are really just seeing that one prescriber all the time in our system, which is ideally how it should be. And just the logistics of our clinic is where it gets distributed that way, unfortunately, from the real world aspect of this.
Okay, thank you. So the next thing that I wanted to ask you about is, as you're employing your clinic specific risk mitigation strategies, whether it's looking at the PMP, doing urine drug screening, some places do observed pill counts. I'm not really sure how I feel about that, but it is something that's out there in the literature. I guess I'm curious, Dr. Liebovitz, at what point in time do you feel, or do you state that, okay, we've had you on regular routine chronic opioid therapy for chronic pain, and at this point in time, not because it's not working, but because of potential non-reassuring behaviors or findings or labs on the tox screens or something that doesn't look correct on the PMP. How do you decide when it's time to taper, when the risk outweighs the benefit of the drug?
Right. So actually, in my practice for all patients, just given the risks of falls, other issues that occur in, just from the nature of the medications, if someone is stable, I'm always trying to go down a bit, again, at a really slow pace, indicating that they really shouldn't notice any change in their pain management, just to get them on the lowest dose to where we're, pushing that a bit, and then we'll hold at that level for a while and then continue and explaining the context then for the patients, and the justification of why we're continuing to go down. In terms of like behaviors though, then, so I'm doing it for all patients. In terms of other concerning behaviors that come up, patients who keep canceling appointments, aren't coming in. So, and that's probably the more common sort of thing. And it turns out, and this is tough, and it's important to not be too draconian in this regard, and to really look at the individual. I've had a number of patients who fall into like high levels of medical complexity and high levels of social stress complexity that end up in that area. And the last thing they need then is being kicked out of the practice or having their opioids completely cut off. So it's more kind of working with the person as a unique individual, understanding an example. I'll paraphrase a little bit, but someone who had a transplant, has chronic joint pain, and is finally back at work at a job, and has two jobs, in fact, because they're supporting someone else, and has been on a moderate chronic opioid dose that have been working to get off, and then doesn't come in for the visit or misses it. But then you get the request, please refill. Yeah. And that sort of thing. And so fortunately, at least in our telehealth supported time, it's easier for me to make time on a schedule, in a sense, to call them, and Medicare, Medicaid still has some coverage for this, for the telehealth visits, as opposed to just at the end of the day to be adding this in. They're not, it's easy to say, oh, they're not following the rules, just gone, but the reality of life is those are the patients are vulnerable, at risk, and for so many different reasons. So I'll talk with them, about why this is so important, and I'll work with them in that regard. And, just listening to the stresses that those patients are undergoing, who often fall into that category, taking the time to do that is what's really essential, and working with them. And then they will come in and they do follow up, but that's where I do end up bending the rules for that. So, because usually there's now, and the ones who are the really like diverting and other things, fortunately, few and far between that I've seen in my practice. Most that when it's not following the rules, there's like a mess of other family stuff and other things ongoing. And I'll explain why I'm concerned about this. Want to make sure they're not giving their opioids to other family members. Want to make sure that they're actually their conditions are under control and understand. So anyway, most fall into that they're doing the best they can and life is overwhelming, as opposed to that diverting that I haven't had too much contact with, fortunately.
Okay, so not to press you on the same question, but I guess
Sure.
for a couple specific examples, like let's say you have a patient you've got on long-term hydrocodone, you do a toxicology screen and you find oxycodone, and you've talked to the toxicologist. No, there's not cross, all that stuff. You know, do you keep track of like the strikes or the treatment agreement violations? Or is there a point where they cross, you draw a line in the sand, and you've decided this isn't going to work for you anymore?
Yeah, there absolutely would be. Fortunately, it's been quite a while. It's been a number of years, actually, that in the practice that I've specifically encountered on. Now, it may just be the filter through which the patients are ending up in our academic internal medicine practice of late. But nevertheless, yeah, having encountered in the past, and yes, we're in discussions with them and understanding this and trying to work with them. It becomes evident that no, they're just asking for it and there is no medical rationale basis, understanding. There's too many inconsistencies. This makes no sense. I will work to transition them together with the practice administrator for them to transition to another practice. We fortunately have like a formalized approach for going through that. So now I'm saying this is where to work with the practice administration so that, you know, the key steps are kind of there, that we've had an established kind of contract for how we should be working. This has not been followed. There have been discussions. This continues to be an issue. Therefore, we're going to work to arrange for another physician to provide ongoing care in this regard. And so we have a practice where the practice administrator will then help with that transition. So part of it is setting those rules in place and planning ahead of time is really helpful so that the doctors, you know, don't feel abandoned in this regard and on their own and how to navigate this, but there's some support for them. And then also it helps standardize the process within a practice so that some physicians aren't, you know, if in a joint practice aren't like willy-nilly, you know, you violate, right, just gonna be gone and being draconian. But no, you know, our practice is this is what we're going to do first to really effectively treat these vulnerable patients who are on opioids to begin with, realize they're going to be the occasional bad apple. And in that regard, we really need to have this in place so that we know how to follow it and still provide continuity of care in that context.
Okay, so you may not have to deal with this frequently, but I know I speak for at least myself. What do you do with the positive THCs on your drug screen for your patients on opioids? Anything?
So yes, part of it is typically, even though there are no additional, you know, substances to be, this is not infrequent, and I'm cautioning them about it. I'm not there. This is not resulting in escalation in that regard.
Okay. I'm sorry I threw you a
Yeah.
curveball. That wasn't.
No, not at all.
We struggle with that as well in our clinic. I would like to make sure that we give Dr. Liebovitz at least a few minutes to eat his lunch before he's back at the grind. Are there any questions from the audience, either for Dr. Liebovitz, myself, or any of the PMP representatives regarding either clinical practice, pearls, or specific PMP functionality questions? And please either unmute or throw them into the chat. And while we're waiting on that, thank you again, Dr. Liebovitz, for agreeing to do this. I know that you were super busy today, so thanks for shifting your schedule around a little bit.
Yeah, no, my pleasure. And I'm always happy to talk about this. And I know there's always opportunities to do better with our patients. I'm hopeful that with some of our improved touch points and pain reported outcomes. We have some research studies underway for any of the patients, more patients will get enrolled. So when they are on opioids, they're being surveyed on a routine basis about how well their pain is being controlled through patient-reported outcomes, even in between those visits, to see how things are going, and then help escalate with alternative modalities to further assist with their pain management. Many of the patients in an earlier preliminary version of the study that I was seeing who are on opioids, and somehow I was getting some of these reports, even though I wasn't directly involved with the patients anyway. This was part of this research study where for the residents, I was supervising some of their patients were there. And I would see many of the patients, they're reporting, these scores are really bad all the time and impactful, even when they're on the chronic opioids that they have a contract with another physician, but I prescribed it at one point. So I'm getting some of these updates. And it's just shows how awful the chronic pain is, and the perception and reality in many cases, but still that this is really impacting their life in so many different ways day to day. And we need better, we need to do better, and at least hopefully getting some of this additional in-between visits data about functional status and standardized measures is going to help us identify better approaches to help manage patients, things to automate in a regard in between those visits with the doctor.
Hey, wonderful. Well, like I said, I want to make sure you have time to eat your sandwich before you got to get back to it. I can't thank you enough for spending some of your time with us today. Thank you to the prescription monitoring program for supporting this effort. Just to make sure everyone is aware, this, as well as all the other lunch and learns, will be available to watch retrospectively on the YouTube channel for the PMP, and that is the @ILPMP on YouTube. So with that, I will shut things down. Thanks again, and please stay tuned for some of our future lunch and learns, where we'll be talking about some of the new and exciting functionality around the prescription monitoring program, as well as other tips and tricks to try to help us as clinicians safely take care of our patients in pain. Thanks so much. Have a great weekend. And thank you again, Dr. Liebovitz.
Thank you.